Hi, welcome to Talk Endo. This is the podcast where we talk all things endometriosis research. My name is Abby and I'm here with...
Hi, I'm Alice. I'm an endometriosis patient and research technician with the EXPECT team at the University of Edinburgh.
And hi, I'm Lucy. I'm a consultant gynaecologist and I'm a researcher at the University of Edinburgh.
Amazing. And today we're going to kind of do the full overview of what endometriosis is, which seems like a big topic and quite, I think, overwhelming, especially for people who are in the process of trying to get a diagnosis or have just been diagnosed. I think this is probably a really nice place to have a summary of the very basics of what they need to know. I suppose my first question is, what is endometriosis? At a base level, in like 2 sentences, what is endometriosis?
Okay, so endometriosis is an inflammatory condition that affects about 1 in 10 people that have a uterus, and it's where tissue that is similar to the lining of the womb grows outside of the womb.
My next question is, what are some symptoms that people might be experiencing if they have endometriosis?
Well, I suppose in terms of the people I see in my clinic, we know that there can be really varied symptoms. So some people will have pelvic pain, and that's probably the most common symptom, painful periods. But there are also a lot of other pain symptoms that can come with endometriosis, particularly pain with sex, which I think is one of the things that people are really feel difficult to talk about and can have a huge impact on people's lives, but also pain at other times. So like when you're going to the loo, so having a poo, having a wee, that could be really sore when the bladder's really full. But I think we're now much more aware that it's very much a whole body condition. So things like fatigue can be really, really debilitating. People talk about brain fog. And I think we're becoming much more aware about that kind of whole body approach. But I think one of the really difficult things with endometriosis is it can present in so many different ways. Different people have different components of these symptoms that bother them, whereas some people can have really extensive endometriosis and not actually have much in the way of symptoms. We don't really understand why there's this disconnect between symptoms and the disease that we see.
And do we know what causes endometriosis at the moment?
So I don't think there's any kind of one cause for endometriosis because it's such a kind of multifaceted disorder. One of the main theories, I think, came about in the 1920s, and it's to do with retrograde menstruation. So this is kind of a theory for the explanation of pelvic endometriosis, period that's gone backwards almost.
We know that's really common. So that happened about 90% of people who menstruate, but clearly only 10% of people get endometriosis. So we think there's some other factors affect why in some people that's all just cleared away by your own immune system, and why in other people that those cells, they persist in the pelvis, they develop into the lesions. We think there's a kind of, as Alice said, so environmental factors, immune factors, as well as something to do with people's genetics. But there's a lot of support for the retrograde menstruation theory. So we know that if people have got a blockage to the outflow tract from the womb, they are almost inevitably going to have really severe endometriosis at a very early age. But there are, as Alice says, there are some elements about endometriosis that aren't fully covered by that theory, particularly people who develop endometriosis in your nose or your lungs. But also we know very rarely people who are born without a womb can still develop endometriosis. So we think in some of these people, it can be that actually some of those stem cells, so those early cells that can turn into any type of the cell in the body, actually under certain conditions can develop into endometriosis-like tissue.
And so you kind of touched on it there, genetics-wise. Does it mean that if, another woman in your family has endometriosis, you are more likely to get endometriosis? Is that a thing that has been proven? Or is it just kind of a theory at the moment?
I know from big genetic studies, we know that there's a very strong link to other members of the family. But equally, if you've got a sister or a cousin who's got endometriosis, or your mother had it, it doesn't mean that you're inevitably going to get it, but there is a stronger link between families. There isn't one specific gene that causes endometriosis, but we know that there are a whole host of small genetic changes that are linked with certain types of endometriosis. We also know some of those genetic changes are probably much more strongly linked with the ovarian and deep endometriosis subtypes, and perhaps slightly less strongly with the superficial peritoneal endometriosis, which in itself is probably the most common type of endometriosis.
And that leads really nicely, actually, into the next question of what are the stages of endometriosis? I feel like we see the stages get discussed of like, I had stage 4 endometriosis or things like that. Is there quite a nice, quick way that you can kind of break down those stages and what they mean?
So the idea of staging endometriosis has been around for a long time, and I think particularly that was pushed because there are certain elements of endometriosis that are quite similar to cancer, so cells being in the wrong place, behaving badly. But endometriosis is different to cancer. It doesn't invade in the same way. It doesn't have that potential to metastasize. But one of the things that have been applied to it is a staging system. And the most commonly one, as you alluded to, that staging goes 1, 2, 3, 4. Now, there's a few issues with that staging system. First and foremost, it doesn't in any way correlate to people's symptoms. And also a lot of how that staging was developed, it was driven by fertility. And so lots of it's driven by how much scarring there is around the fallopian tubes and the ovaries, whereas it doesn't actually correspond to perhaps the severity of the endometriosis or the complexity of the endometriosis. And it also doesn't necessarily correlate by how people are going to respond to different treatments. So we now tend to think a bit more in terms of subtypes. So whether or not someone's got superficial peritoneal endometriosis, that's the most common type. These are little lesions lining the peritoneum. So that's the lining of the inside of your pelvis. We call it superficial because it's on the topmost layer. It's in no way to be suggestive of people's symptoms being superficial. People can have really debilitating pain despite it just being peritoneal superficial disease. There's also ovarian endometriosis, and often we call these chocolate cysts because they're cysts are lined with endometriosis tissue, and you get a collection of this fluid that really looks like chocolate sauce when you drain these. And that's just all blood and lots of inflammatory cells within that. And then the other type is called deep endometriosis, and this tends to be a much more scarred form, developing into nodules. Often it sticks between the back of the womb and the bowel or on the sides of the pelvis and can cause problems with obstruction of the kidneys. And this is the type of the disease that is much more complicated for us to deal with surgically, and sometimes also won't necessarily respond quite so well to some of the medical treatments we use for endometriosis. And I think that's probably because it's often a lot more scarred. So we lose those hormone receptors in the lesions that are perhaps more present in some of the other subtypes. So as a consequence, people tend not to respond to hormonal treatment often as well compared to some of the other subtypes. But I think what's very much gone throughout there in sort of public understanding is people talk about the stages, but I often find that really unhelpful. It doesn't correspond to pain. It doesn't correspond to other symptoms. It doesn't correspond to surgical complexity. And also it doesn't correspond to how someone's going to respond to a treatment. So I think we're trying to be much more precise about how we define endometriosis in terms of the subtypes.
And I suppose, so if someone is kind of recognised their symptoms, they think it's endometriosis, what is the pathway then to getting that diagnosed? We know that it takes, on average now, I think it's 9 years and 4 months. We know that that process is quite long, but kind of what would be the first step that they should take, and then how can they get an official diagnosis as well? What is the kind of way to diagnose endometriosis currently?
So there's a lot to unpack in there. I think firstly is someone recognising that what they've got is not normal. And we know that on average, from people starting to experience symptoms to actually seeking help from a healthcare professional in the first place, that's usually about 3 years. And I think that's a lot because we normalise what happens with our periods, but recognising that if you've got pain that's stopping you doing what you want to do, that is not normal. So whether or not you're missing school, you're not able to go to work, you're not able to participate in the activities that you normally want, that's something, a sign of something not being quite right. Also often really heavy periods, so leaking, passing clots, and then all the bowel symptoms. Again, if you've got these symptoms, go and speak to your GP, and that would be the first step. There's really useful information from some of the patient support organisations like Endometriosis UK, Wellbeing of Women, about how to try and write down and get an overview of what your symptoms are. And then actually means you can have a much more productive conversation with your GP about having recognised how do these symptoms relate to your cycle, because often at the beginning they're much worse around the time of your period or when you're ovulating, although we do know over time often that change across your cycle does go, which makes it harder to unpick. But if you've got these symptoms, go and speak to your GP. Now, when you go and see your GP, there's lots of different things that they have to think about. And depending on your age, some of the character of some of the symptoms, often they've got to rule out things that might be more sinister than endometriosis first. And they might also do some tests. So that might include screening for infections, both gynae infections, bladder infections, looking for things like inflammatory bowel disease. But what a common thing they will do when they see you in their GP surgery is that they will often examine you. And we might sometimes find features of endometriosis on examination, but we also might find other causes. So can they feel a fibroid, which is swelling in the muscle layer of the womb, or an ovarian cyst? And often what they will do to try and get more information there is arrange for an ultrasound scan. Now, an ultrasound scan can see ovarian endometriosis. It can sometimes see deep endometriosis in expert hands, but what it won't see is superficial peritoneal endometriosis. And that affects about 80% of all the people with endometriosis. So even if the ultrasound scan is normal, it's really important. That doesn't mean that the person doesn't have endometriosis. But if it does show features of endometriosis, then that can be very much considered a valid diagnosis. So in terms of what happens next, we know that at least 50% of the people who present with all these symptoms will have endometriosis. So our guidelines now very much are working towards having a working diagnosis or a clinical diagnosis of endometriosis. And so we should be offering these people treatment to manage those symptoms. And that includes painkillers, but also because the cells are like the lining of the womb, they've got estrogen receptors, they've got progesterone receptors. We use hormone treatments a lot to help manage endometriosis, and that's both to help with people's symptoms. That's ultimately what most people care about. They want to not be in pain. They want to not have really heavy bleeding. They want to be able to do what they want to do. So hormone treatments can be really effective to treat that. But also because it's targeting the endometriosis cells directly, it can also often help shrink the lesions and make the disease less inflammatory. So they can be really, really effective. But equally, they don't work for everyone. They do have side effects. Not all the hormonal treatments are appropriate for everybody. And they're also contraceptive. So if someone's trying to get pregnant, then having a hormonal treatment isn't appropriate for them. But if someone can take hormones and they are appropriate for them, that can be a really effective treatment for them. And they actually never need to go further in that journey. But I think it's really important if either people can't have hormonal treatment or it doesn't work for them, or there are features of more severe endometriosis. So big endometriosis cysts on the ovaries, you can feel or see endometriosis on examination, then that should prompt a referral into gynecology. And then we can do further investigations. Sometimes that might be a slightly different type of scan called an MRI scan. Now that can identify deep endometriosis, but again, that still won't identify peritoneal endometriosis. So if people have got ongoing symptoms and are still seeking a formal diagnosis, then the next step would be to perform keyhole surgery or a diagnostic laparoscopy. And that allows us to really carefully inspect the whole of the abdominal cavity to look for endometriosis. And then if we see that, then it confirms the diagnosis. And typically, if we talk about the gold standard of diagnosis, we would also then remove a bit of the tissue and send it off to the laboratory to have it confirmed by a pathologist under a microscope. Yeah. But I think lots of people have different experiences of the diagnostic pathway. Some people go through it really quickly. Some people go through it much more so. You talked about the big diagnostic delay. Alex, have you got, having gone through it yourself?
Yeah.
What are your thoughts?
I think it's, it takes so many steps to get from where you are right at the beginning, which is somebody that's in pain, to then ending up with maybe a diagnosis. And I think the difficult thing is that people quite often have quite an unpleasant experience with that. From what I've heard, a lot of people talk about maybe feeling dismissed, but, perhaps that's to do with a lack of kind of education about what endometriosis might look like at the earlier stages, kind of before a gynecologist. I think one of the things that is most helpful throughout that whole process, definitely for me, is to keep a track of your symptoms, like you were saying, a kind of symptom log. What I would do is I would write down kind of stage of your cycle, your symptoms, maybe your bowel symptoms, if you're on your period, whether you're having period pain. And then I would also consider writing down maybe what you've been eating that day or what painkillers you've taken. And all of that information is excellent data to be able to bring to the doctor in the first place so that you can start kind of down that pipeline. And I think the Endo 1000 app that we have as well has got really amazing trackers on it where you can put all your symptoms down in one place and you can see them. They kind of come up as nice little graphs and everything. So that's a really accessible way for people to kind of track their symptoms. But it also allows you to collect all of that data for down the line when you might be speaking to a doctor or a gynecologist as well.
Yeah, especially because to take part in Endo 1000 in that tracker section, you don't need to have that confirmed diagnosis. It can be suspected.
Yeah.
And so I do think that's a really good, empowering way to kind of give people the opportunity to take something physical and say, here are all of the reasons that I think this thing.
Definitely. And I think it's worth maybe noting down as well, symptoms that people might not think are typically associated with endometriosis, whether that's kind of bowel symptoms or bladder symptoms, pain when they go to the toilet. These are the things that maybe we just think of endometriosis as painful periods, but it's actually really important to keep a track of those other bodily symptoms as well.
And it's something I have to say, when someone comes and sees me, if they've actually really thought about how it all relates to the cycle, it makes it all so much more straightforward and makes it a much more efficient consultation. So I think sometimes people worry about coming and going, here, let me present you with my data.
Yeah.
But actually, it's really, really useful. And I think also that time when you do track things, it allows you to reflect on those subtle variations in the pattern, particularly how it might relate to your cycle if you are having menstrual cycles. So I find it really, really useful. And I think it also helps often crystallize people what actually are their most impactful symptoms. What are the bit that's really important for them to get help with?
Yeah, definitely. And I feel like it helps people kind of achieve a sense of control in that process as well. I think it quite often is quite a difficult and, as we know, long process at the moment. But that kind of keeping track of people's symptoms, that can maybe help them to feel a little bit more in control and a little bit more educated about their own body so that they can kind of bring that to the professionals down the line. But to feel comforted in their own kind of knowledge of what they've got going on as well.
And I think particularly also you made that point about things like associated with your diet. We know that of our existing treatments for endometriosis, they will work well for many, but not for everyone. Yeah. And I think often we're now moving to a much more sort of multimodal approach to manage endometriosis. And some of that's about giving people strategies for self-management. Now, it's not putting all the pressure on them to manage their symptoms, but actually if you can give people tools where they recognise for themselves what are their individual triggers, then they can make conscious choices about what they do with what they eat, what they're drinking, their activities. And I think, it's one of the things about endometriosis, it's so debilitating, but also it can be really unpredictable. And that loss of control, I think, must be so hard to live with. So anything that gives you insights about how actually you can have some control over things, I think will be really helpful.
Yeah, absolutely. And then, of course, as you were saying, there's going to be times where you've thought, okay, I've eaten everything correctly. These are the things that usually work for me, and I'm still experiencing this kind of horrible flare. But it's all information that's kind of worth having if you can collect that, and then you can kind of use it to predict trends over time. I think the more that you kind of know about your own body and the more informed that you stay on the trends that you're seeing, the easier you are to communicate that to a doctor as well, who's then going to be able to give you the kind of right kind of help.
And then, so we've spoken about hormones, we've kind of spoken about lifestyle and things like that. A lot of what you see around endometriosis does tend to be information about surgeries and hysterectomies. When would be the point that you would kind of suggest that as a treatment option? How do you help people through that as well?
So I think it is always going to be a very individual decision. And I think it's whenever we're offering an intervention, whether that's medicine or surgery, it's going, what are the risks? What are the benefits? What are the alternatives? What if I do nothing? And I think one of the difficult places where we're in is actually in terms of our evidence base around all our interventions, but actually particularly surgery, is that we don't actually have that great an evidence base to help someone to decide about whether or not it's the right thing for them. So, and I think this is where actually particularly the staging system has been really unhelpful because that has an impact both on the risks and the benefits. So someone can have deep endometriosis and actually technically be an earlier stage disease or have disease that it's all superficial, but actually it's on the bowel. So it's still superficial, it's still on that topmost lining, but actually that represents a really complicated operation that I might want a bowel surgeon to be there. And the risk for that person is so much more. But actually, if you go with the stages, it wouldn't sound like it was a very complicated disease. So I do try to think quite carefully both about what subtype of disease is and also what the location of the disease is. So there is from big, what we call cohort studies. So these are studies where we've taken loads and loads of people who've gone through the same operation. There's some really, really large cohort studies about surgery for deep endometriosis, particularly involving deep endometriosis between the back of the womb and the bowel, so what we call the rectovaginal disease. And that's from data that's fed into what we call the British Society of Gynecology Endoscopy database. So every BSG centre in the UK, so that's these big specialist centres for where we're managing complex endometriosis, we all feed our data into that national database. And that's given us some really helpful outcomes about how we can counsel people of the likelihood of their surgery improving their quality of life and pain. And what we would say for someone with deep endometriosis, say we've got around a 70% chance of significantly improving your pain and your quality of life, and that being maintained at 2 years after your operation. But we've also got really good data about what the risks of surgery, and we'd say the risk of a serious complication from that operation is just under 7%. So that's why we do these operations in part of as expert surgical team, both from a gynecology aspect and having in other specialties such as bowel surgery or bladder surgeons where necessary. But we don't have really big randomized controlled trials of saying comparing that type of surgery to, say, medical treatments or that sort of surgery when people either know they've had it or they don't know they've had it, which is the gold standard of kind of giving the best possible evidence. But it's really difficult to try and do that type of trial. And I think we'll probably never do it. But from these really, really big cohort studies, I think we can be reasonably confident that surgery for deep endometriosis, so removing the disease, will help. What's also come out of that database, if people have a hysterectomy as well, will have a slightly added benefit. And then if they have their ovaries as well, they're even less likely to come back and see us with recurrent or persistent symptoms. But what we can't tease out from that data is how much of that removal of the womb was driven by people having really heavy periods or having a condition that often comes along with endometriosis called adenomyosis. So I call it the cousin of endometriosis. It cells similar to the lining womb, exactly like endometriosis, but instead they're in the muscle layer of the womb and they can cause really heavy, painful periods. And so often surgery to remove the womb can be really helpful for those people. But clearly someone has to either have completed their family or not seeking fertility in the future before you make that very irrevocable step. And again, the same with removing just the endometriosis is not a guarantee of that things will necessarily be better for all people. And very occasionally we can have people whose pain's worse after surgery. That sort of surgery also has got risks associated with it. And if we take the ovaries as well, we've got to consider about what are the risks of an early menopause, both in terms of people having increased cardiovascular risks, so heart attacks, strokes, risk of osteoporosis, but also the impact of an early menopause on quality of life. And for some people, we control those menopausal symptoms really well with HRT, but for others, we can't necessarily get on top of them. And if we're doing an operation for quality of life, then I think we need to be really mindful about what are the potential outcomes that we perhaps don't necessarily think of as carefully about, such as early menopause symptoms. So that's deep endometriosis. That's probably a longer answer than you wanted.
No, it's interesting. I really like this is the kind of information that I think people are wanting, and knowing that people who are treating them are putting everything down this detail to say, you know, I'm empowering you to make your choice, but here are all of the kind of lists of the risks, the benefits, what we think could help. Just having all of that there and knowing that you've not got a consultant who is just saying, do this, do that, allowing people to have that look and empowering them with the knowledge of what they're about to go through is fantastic.
Yeah, supporting them to make the right decision for what they feel is the right decision, but trying to give them as much information in an accessible way to help them make that decision. I think when we think about the other subtypes of endometriosis, so ovarian endometriosis, we know if we remove that surgically, the majority of people will have improvement of their pain. And if we remove the cyst in its entirety, it's much less likely to come back. So that's the benefits: improved pain, less risk of recurrence. But we've got to also, again, think about the risks. If we're operating on the ovary, inevitably we are going to reduce the amount of the eggs inside the ovary. And that might have implications for people's fertility in the future. And also, if we remove cysts from both ovaries at the same time, there's a small chance that actually both those ovaries don't work afterwards. Now, that's not common, and it's more likely to happen if, say, we've operated on them before, and someone's a little bit older. But if you've not completed your family and we operate on your both ovaries and you wake up and your ovaries don't work, that's devastating.
Yeah.
There's also a small risk when we are operating on the ovary that we can have lots of bleeding. And then that, very occasionally there's a risk of having to remove the ovary. Now, that's really, really rare. But again, is one of the risks we need to think about. And often it's putting it in context from the individual. So if someone's got a really good ovarian reserve, they've just got one endometrioma, they've not had any other surgery on their ovaries in the past, and then we would be, feel more confident about the risk-benefit ratio is worth laying up. But if someone's already had multiple surgeries on an ovary, or they've only got one ovary left and they're desperately wanting children, then we need to think really carefully about, is removing that cyst the right thing to do them, or should we be taking other approaches, medical management, and also helping support them in their fertility aspirations if that's what they want. So the one that I think is most complicated is what's the role of surgery for superficial peritoneal endometriosis. And this is something that is really difficult because it's the most common type of endometriosis. And at the moment, our guidelines very much do say offer removal of that disease if we see it, if it's straightforward to treat. And usually often that's done at the same time as a diagnostic laparoscopy to investigate whether or not someone does or doesn't have endometriosis. But the evidence base to support that, when you drill into it, is actually really terrible. So there were 3 trials that were done to inform our NICE guidelines here in the UK. And putting all those people together, that was 171 patients. So half of them across those 3 trials, half of them had their disease removed, half of them didn't. And there was improvement in those who had their disease removed. But those patients were only followed up for 6 months, apart from one of the trials. So one of them followed them up to 12 months. But that was only 69 of the people. None of them followed them up any further. And we know that people have got a really high rate of coming back to see us in clinic after they've had surgery with recurrent or persistent symptoms. Now, the figure we quote is a really old one. It's 50%. But that's a figure that's over 15 years old. And that's of the ones who come back to gynecology. And actually, if you look at surveys of people in primary care or in the community, actually the rates of persistent or recurrent pain are much, much higher, and actually could be as high as 89% after 2 years. So that was a really big survey done by Endometriosis UK. So I think this has been this slow recognition of, A, we've not followed people up for long enough. 2, those studies that support doing that type of surgery are really small. And also that when those studies were done, they weren't necessarily perfectly subtyping because they often were driven by stage rather than subtype. And people can have other subtypes of deep endometriosis and still be a stage 1 or a stage 2. So I think recognising that we think there's possibly often a different response to treatment. There's a real need for a much bigger trial to better answer this question, to be able to help people to make a decision about how likely is this to help me and how likely is it to help me in the long term. Also a better understanding of what the risks of removing that type of endometriosis are. And then ultimately thinking about how that sits compared to some of the options we can offer people. So this is something that's been recognised by the whole, both clinical community and the research community, that we needed to do a bigger trial. The NICE guidelines recognise that. So they specifically asked the main government funder for research to put money into this type of trial. And that's what we've done in the ESPRIT 2 trial. So that's the biggest trial of superficial endometriosis that's ever been done. So 400 people have been randomised to either have their disease removed at the time of a diagnostic laparoscopy or not have it removed. And they don't know, and they don't know until 12 months, and then we tell them. And what we do is we collect outcomes, not just about their pain, but all those other facets of the endometriosis experience, from their bladder symptoms, their bowel symptoms, what's happened to their fertility. And actually those people participating in the trial, they're going to be followed up for 5 years. So I think that's going to give us much better evidence with which to help counsel people, to help them decide what the right thing is for them. I think one of the things that's also really often talked about, particularly in the context of superficial endometriosis, is of this debate about excision versus ablation. So we can cut the endometriosis out, or we can burn it away either using heat or with a laser.
We were talking about that the other day, weren't we?
And I think there's quite a strong narrative saying that, excision is much better than ablation. And I think some of this has been conflated with deep disease. If you just try and heat treat the top of a deep lesion, you're not going to be treating it. So you do have to excise deep endometriosis. But for peritoneal endometriosis, we can absolutely destroy all those endometriosis lesions with heat. And in terms of the really small studies that have been done about trying to compare excision versus ablation, actually the only symptom that seems to come out strongly is improvement in painful sex. So there's this narrative that we must excise endometriosis, but we actually don't know for certain if that's really true. And I think we have to consider that with both approaches, you've still got the risk of scar tissue. We know that endometriosis encourages the growth of new nerve fibres, as well as for those existing nerve fibres in the lesions, they get really irritated and sensitive. And I think we've slightly ignored what the potential is for surgery to cause damage to those nerve fibres and actually perpetuate some of the pain that people experience. So even though the lesion's gone, lots of people have ongoing pain, and it's because of something that we've done surgically. And certainly there's good evidence that the more operations someone has, the higher proportion of them will have what we call a neuropathic component of pain, so pain that's been driven by these nerve fibres. Now, that's slightly difficult data, because what we don't know is, with people who've got underlying neuropathic pain, are they less likely to respond to surgery, so they keep on coming back and we go, well, the hormone treatments aren't working, so let's just do another operation. And so is that why we start seeing a disproportionate number of people with neuropathic pain who've had multiple laparoscopies? But has it also been driven by what we've done surgically? And I think we don't really know. And I think particularly now with some of the newer surgical techniques, so using robots, which allow us to do these really extensive, very beautiful looking dissections of people taking away all the peritoneum in the pelvis. And I really worry about what that's doing to those nerve fibres. And also the risk of scarring in the future. So whilst it's very much a debate, and it's a debate that's not going to be answered by ESPRIT 2, that was not what it was designed to do. We took very much the approach of, this is a trial that's for what happen to people when they present for their first laparoscopies, which is often done in district general hospitals. Different people will have different approaches to managing them. So we will report the excision versus ablation, but it's the excision outcomes and the ablation outcomes, but it's not what the trial was designed to answer. But I think it is a really complicated space. But I think we do need to be mindful about what some of the potential complications are from surgery, as well as the potential benefits. And what we really need is just better evidence to say, look, this is the likely outcomes. And also, actually, I think moving towards more precision care. And because we do have some patients who do respond really well to surgery, so can we try and find the tools to be able to predict who are the ones who are really like to respond to surgery, in which case saying, look, if you have surgery, this is your likely benefits. Whereas those who go, actually, we know you're in the group that you're unlikely to do well with surgery. So there's probably not a big benefit in exposing yourself to those risks of surgery when you're not going to get much benefit. And actually, we really should be focusing some of those other treatments. And at the moment, those other treatments predominantly are hormonal treatments, pain management, and some of those other approaches from changing your diet, doing things with your microbiome. But I think in the future, as we stop thinking about endometriosis as a purely hormonally driven condition to a more neuroinflammatory condition, actually that opens out to so many different treatments, particularly treatments that are already around for other inflammatory conditions, but also disease treatments that are more specifically aligned to endometriosis and addressing that inflammatory component in particular.
Yeah.
I also think the gut is absolutely fascinating. And I think what we were saying to
We've had
people...
big conversations about this.
We are all about the gut.
but I think what we're saying to people as clinicians in 5 years' time will be different to what we're saying now. I think we absolutely recognise people are much more likely to have IBS if you've got endometriosis as well. And I think in the past, people thought it was always an either or an or.
Yeah.
And now we absolutely recognise those two things coexist and are much more likely to coexist. But how people can manage that with change to their diet.
We were talking about this as well.
We
weren't
were, yeah.
The infamous endobelly.
Yes, absolutely. And how unpredictable it is in everything and how varied it is. I think it's such a kind of varying disease person to person as well, isn't it? So that can be also why it's really difficult to spot sometimes. I think what Lucy was saying about the research being there to maybe start to consider it, you know, more as a whole body disorder and to focus less on the kind of surgery route straight away, because obviously there is such a massive kind of waiting time at the minute. And I think for the people in the community, that's very frustrating. But like you were saying, Lucy, if there was a way to kind of start to think, is it you that surgery would actually be useful for, or is there another form of treatment? I think for a person who is suffering through a lot of pain, to have to kind of come to that decision themselves, often when they're actually not with an endometriosis specialist, maybe when they're just kind of beginning to talk to a GP or things like that, to have that kind of pipeline with the research, that would be a fantastic tool to be able to guide people in the right direction and hopefully reduce that waiting time as well for people to get an intervention that is actually going to be, you know, successful for them. And I think with Endo 1000 as well, we've got all of the information coming in about when people have had surgeries, and then they'll be telling us about their kind of pain as well after that. We'll get the samples back from after their surgeries so we can check for things like inflammation. But that's a really important component, I think, of Endo 1000, is that we do want to follow up after people have had that treatment as well. So it'll be really interesting to think.
Yeah, and it'll be really nice to see how that data then maps onto what we find from the big surgical trial where we've, you know, phenotyped people as well.
Yeah,
for that.
absolutely.
I also think the bladder is really interesting and often, again, probably slightly missed. And I think particularly if, you know, people have got this kind of very inflammatory process going on, what that does to the sensitization of your bladder. And so things that if you didn't have all that information, you cope with, particularly like usual things like caffeine, fizzy drinks.
Yeah.
Actually, if you've got all that inflammation and an irritable bladder, then you're not going to cope as well with those challenges.
Yeah.
So again, giving people the tools to recognize that and then helping justify about why they should make those changes.
Yeah.
But also trying to recognize of who the people that actually, if they make all those changes, it's going to make no difference. So, you know, for those people, actually, they're not denying them things that they really like.
Yeah, yeah.
So again, it's trying to get to the right thing for the right person and doing it more quickly and ideally in an evidence-based way. I also think the microbiome is absolutely fascinating.
Crucial, yes.
And I'm desperate to do a kefir trial. I think that would be fascinating.
Amazing. I mean, your individual microbiome profile can be completely different to somebody else's. And it's these kind of biomarkers that we're looking for through the kind of research to suggest actually we want more of an individualistic kind of approach to endometriosis. So whether your kind of markers of inflammation, I know through the EndoFlare study that we did, which was the kind of precursor slightly to Endo 1000, that was just 10 patients. But even within that, in my kind of master's research, we saw that, you know, these inflammatory markers were changing across the months, and we could see maybe trends within people, but it didn't apply across the board. It was completely different between everybody. I think that just shows kind of we try and kind of categorize all the symptoms in the same way. At the minute, kind of the treatment pipeline kind of looks similarly, but actually to be able to get to a point with studies like Endo 1000 where maybe we can find some biomarkers to signal what would be specifically helpful to that patient, I think that's where things are going to really change for the better.
And I suppose that crossover of the different trials that you are doing as well is really helpful. So pairing the surgery trial with Endo 1000.
Yeah. And then also thinking about how people's genetics play into that as well. And the genetics is not just about your risk of endometriosis, but we're also increasingly aware that your genetics might have an impact on whether or not you're likely to respond to a certain medication. And there's a really good example. So if people have a stroke now, we would often use a drug called clopidogrel, but they know that a proportion of people have got a certain variant of a gene that means that they won't respond to. So now, if you're going to be considered for that drug, they'll do a genetic test. And if you've got one variant, they just won't give it to you because it won't work. So they can then just give the people who it's likely to be effective for. And I think, we're becoming... we did some, as a consequence of one of our other really big trials, which was a medical trial using a drug called gabapentin for people who didn't have endometriosis but did have pelvic pain. And that was a really, really big study. And ultimately, it did show that actually gabapentin wasn't effective and was also associated with more side effects. But we knew in that study there was a group of people who did do really well on it. And when we did a genetic screening test across those people, those who did well and those who didn't do well, actually there was a genetic marker that was really strongly associated with whether or not you were likely to respond to gabapentin. So that gives us the opportunity to say, well, look, we shouldn't blanketly prescribe this to everyone with pelvic pain who don't have endometriosis to help their symptoms. But actually, if we can do some other studies to confirm this finding, actually there's potential to say, well, actually, maybe we should do this genetic test. And if you've got the variant that's likely to respond, then we can consider a trial of gabapentin. So again, it's moving towards that more precision-based approach. We also know that your genetics can also interplay about your risk of side effects from a drug as well. And that was one of the really interesting things when we did the EPIC trial, which was using a drug called dichloroacetate. And I don't know if you've already spoken about this in some of the other episodes of the podcast.
Not yet, no.
But this was a whole piece of work that came out from people who'd undergone surgery in Edinburgh who'd very kindly allowed us to have some of their samples taken at the time of the surgery. And we had both people with pain who were found not to have endometriosis, people who had pain who did have endometriosis, people who had no pain but actually incidentally had endometriosis, and people who were having surgery for completely different reasons, so no pain, no endometriosis. And we could look at changes in the cells, in the fluid in their pelvis, and we found that there was this really striking change in their metabolism. So we had very high levels of lactate. So you might know lactate so if you go for a run and get a stitch, it's build-up of lactate in your muscles. But you can also get changes where you have increased levels of lactate without having done loads of exercise. And we found that there was some of the enzymes that changed in people with endometriosis. Now, we don't know if this made them more susceptible to having endometriosis or if this was implicated in their symptoms. But what we were able to then show in our laboratory models that we could also recreate this example where you have these raised levels of lactates. And then we looked around for drugs that have treat increased levels of lactate. And when we treated our laboratory models with these drugs, it really reduced down the levels of lactate, but also the pain behaviours changed, the size of the lesions shrunk. So this was really encouraging. So there's a drug called dichloroacetate, which has been around for decades and was used to treat metabolic disorders in children. So we did a really small proof of concept study where we took 30 people, all had known superficial endometriosis. So this was the same as the people we'd got the samples from in the first place. And we treated them with this drug for 12 weeks. And now this wasn't a study designed to say, does this definitely work or not? But we got some really exciting preliminary data about impact on symptoms. But what was really interesting is that some people in that group got some side effects from the drug. Now, these were known side effects from the drug, and particularly you can get a tingling in your fingers. And it's very much related to the level of the drug in your system. Now, we had people on a really low dose of this drug. So we're slightly surprised that some people got this side effect. But when we looked at their levels of the drug in their body, they had really high levels. And so you can actually go and look at the enzyme that metabolizes this drug. So that affects how quickly it comes out of your body. And they had a version of the enzyme that meant you accumulated the drug. So that meant you were much higher risk of side effects. So what we can then do is we can actually test people for their genetics at the beginning, and then we can give them a personalized dose, which hopefully will allow us to both still have that impact on their symptoms, but minimize the risk of the side effects. So that's what we're doing in the EPIC-2 trial is we are taking 100 people in Edinburgh and London. We're going to genetically test them at the beginning, and then half of them are going to get dummy tablets, half of them are going to get the active drug, but they're going to get a personalised dose, and then we see what impact that has on their pain and quality of life and other symptoms. So that's another interesting way where we can bring in genetics, not just to look at risk or response to treatment, but also side effects. So I think, again, historically we had look, these are our list of treatments. It's not a very long list, and we'll just work our way through them with an element of trying to adjust for what your fertility aspirations are, what your previous side effects are, and to an extent also what your symptoms are. Whereas now, hopefully, I think we can be much more precise in the future about what we recommend to an individual person, but also encompassing their current and future fertility aspirations and their other risk factors and other features.
A proper blanket of personalised care, super personalised care, which I think is what a lot of the community are looking for. They want that thing that is going to be specific for them and work for them, because I think for so long it's just been that blanket of like take some hormones and that sort of thing.
I think it is really exciting for people to be able to hear as well that there are options out there other than just take the pill or get pregnant sort of thing, which I think is what a lot of people have kind of reported being told. But I think it's really exciting, and it gives people a lot of hope to know that these kind of trials are going on, and there is kind of continuous research all the time into other alternative treatments. I think that's really, that can give people some real hope from the community. Just knowing that, treatments are always getting more personalized, and the more data that we can get from people, kind of the better. And it's why it's so crucial for studies like Endo 1000 to happen, and why we're so kind of appreciative of everybody that's sending it through their samples. This all kind of leads us towards that more personalized approach, which I know has been a kind of major issue with a lot of people who might have tried the pill and not gotten well with the pill, or like I was on the pill for about 6 years, I think, never got on well with it. So I think that just people knowing as well that there are those different treatment options out there, that's really helpful for people to be able to talk to their doctors about too, I think.
I think it's something that I personally never would have considered even being a thing as well, like taking a drug from elsewhere that works really perfectly. I would never have thought of kind of that then being able to work somewhere else. And so that's the wonder of your guys' brains, is being able to look at these things and just think, well, we know that does that. What if we then tried to do it with that? I just think that's so clever.
Well, I think it's also, a lot of it's been driven as our understanding of endometriosis improved. As I said, it used to be a very hormone-centric approach, whereas now we appreciate much more the neuroinflammatory component of endometriosis. And that does really open up the options for repurposing drugs, because to develop a new drug and bring it through to a point where you can actually prescribe to people, that's decades and billions of dollars of research funding. Whereas actually, if you can repurpose something, and it means it's much faster to actually making a difference to people. But it also improves outcomes. And I also think it's this understanding the disease that drives better care. And I think the example I often think of as we think about breast cancer, so in the 70s, breast cancer outcomes were dreadful. Lots of people would die at a young age. And the treatments, the surgery was really, really aggressive. The chemotherapy regimes were awful. Whereas now, and lots of people still didn't survive. Whereas now, instead of just thinking about breast cancer, it's not just broken down by the hormone receptors, it's also broken down by different genetic changes. And that has meant a huge plethora of changes. Surgery is now much less aggressive. The chemotherapy regimes are often easier, but not necessarily. I think still it's tough for a lot of people, but also crucially, they're so much more effective. So I think it's that better understanding of the disease. I think we have recognised that endometriosis is not one single condition. It's incredibly heterogeneous, and it's not, I think also moving away from that very lesion-centric approach, thinking about, differences in people's immune systems, their genetics, those environmental factors are all really important things to consider.
And it's amazing that all of these trials are coming out now as well. Like, just hearing bits and pieces about what is going on around the office is just fantastic.
And I think it's a really exciting space, and it's a really exciting space for us as researchers, but also it's a really exciting space for me as a clinician to say, the people are sitting around going, actually, there's real hope. There are new things coming through. And I also find the endometriosis patients are an amazing group to work with. And I think it's partly because they've had such a difficult time for such a long time. I think also many people are aware that there is that familial link. And often I have people saying, look, I'm not doing this for me, I'm doing it for my daughter.
Yeah.
I hope she'll never get it, but if she does get it, I hope there will be better choices for her. So I think that's one of the things that's really inspiring, and it's one of the aspects I really love about my job is actually getting to work with all these amazing people, both the people who take part in our trials, but also the people with lived experience who help us design our studies so that they are really addressing the questions that they care about.
Yeah. I mean, that's kind of what's gotten us to this point as well, isn't it? Is people telling us, actually, it's not just period pain that I'm kind of experiencing. That has motivated other studies that are maybe related more to the gut or to the bladder. And it's kind of listening to those patients and that community, which is such a tight-knit community, I feel. And yeah, like you said, united by something that is such a horrible disease, but also so nice to have those people around you that kind of fully understand, especially with it kind of being an invisible illness, is that a lot of people kind of don't look sick necessarily when they have endometriosis, but could kind of be going through a horrific time. And because it is so common, I think it is so nice for people to have that online space, or maybe their kind of local spaces to go and discuss endometriosis. But it's, as much as it's important to the patients, it's important to us as researchers as well, that we get that feedback from them about, you know, what symptoms are bothering them the most and things as well. That informs where we go with the future trials. So
yeah, I think you can't underestimate how fantastic having a good clinician and a good team to help you work on these things are. Like, just being able to go and know that you're going to be listened to and understood, and that they are going to take that personal route rather than that blanket route. Just having that knowledge in your brain, I think, really helps people in the community as well. Just having someone who is willing to sit and listen.
yeah,
Even if you sit there, even like, to not have people who, when you go, say something like, I'm getting pain in my leg, is this endometriosis? And someone to just be like, no, absolutely not. Having someone who will listen to you and say, well, actually, let's think about why that could be linked to your endometriosis and look into that a little bit further is really helpful. Because that's something that I saw online too, was people saying they were getting leg pain and didn't realise until years and years and years later that could have been an impact of their endo.
Yeah, and I think particularly a lot of this referred pain that people get, you know, if you're sore, you're going to hold yourself in all sorts of different funny positions. You're going to start to get a lot of myofascial dysfunction, trigger points. The same way, if you think you've got a migraine, you hunch your shoulders and you're really, really tight knit. You know, you've got so much complexity in all your pelvic floor muscles, and you get all sorts of, you know, people holding themselves and you know, shooting pains down their leg. And some of that can also be a lot of the neuropathic pain that we talked about. So those nerve fibers behaving badly. But I think it's also, I'm also equally incredibly conscious that I work in a big tertiary endometriosis centre. So I have people come through to me who've actually had a whole load of things already screened out. Whereas if someone first goes to see their GP, actually they've got to make sure, do they have cancer? Do they have inflammatory bowel disease? Do they have any of these other host of things? And actually there'll be lots of people who present with the symptoms of endometriosis who will actually have one of those other conditions, and then will actually get appropriately filtered through to those other specialties. We also get people coming through to us who are a bit further through and going, actually, this is inflammatory bowel disease, or this is painful bladder syndrome, it's not endometriosis. So I think it's really important to be aware of how our healthcare system works, that we do have to have these screening stages to help. And also the other thing that I recognise, hormonal treatments don't work for everyone, and some people they are not appropriate for, but actually for a lot of people they are really effective. And there's also now really good evidence, if you have a hormonal treatment after an operation, you are much less likely to have recurrent symptoms and recurrent disease. So I think we're in a sort of slightly difficult space at the moment where there's a lot of pushback about hormonal treatments. And I think it's really important that people understand that we are directly treating the disease. We can see lesions shrink with hormonal treatments. They can be incredibly effective. So I completely recognise they're not right for everyone, but I think they're a really important part of our care armamentarium. And I also think there is probably a whole heap of people in the community who never get diagnosed with endometriosis because actually it's really well controlled with the hormonal treatments that that the GPs use in primary care. So I think it's really important that we don't lose sight of that.
Yeah, absolutely. And I suppose in the same way of finding the perfect contraception, finding the perfect kind of route of hormones that will help you treat that thing is going to be a bit of a journey, because the first pill you try isn't always going to be the one that you end up sticking with. I suppose it's looking at the fact that hormones can be really helpful, but you might have to go on a bit of a journey to find the perfect hormone for you as well.
Definitely. I think it's probably also important to raise that we know that this could be frustrating because not everybody's kind of diagnostic process looks like this. And that, you know, we kind of are here and we work with specialist endometriosis surgeons like Lucy, but not everybody has access to that. And so I think that, you know, it's great for us to kind of sit down and say, here are all of the options, and it sounds fantastic. But then when people go to their doctors, not the fault of the doctor at all, because, you know, there's not the funding for them to be specialised in everything, especially with women's health. And I think that, you know, it could be a bit frustrating to go to the doctors and think I'm being given one option. You know, I've heard of all of these options, but actually I'm only being given one. I think that's, again, where that self-advocacy is huge, and that education around it is important, to know that you do have other options, whether you might just have to kind of be active in presenting them. So learning as much as you can about endometriosis, tracking your symptoms, you know, engaging with kind of podcasts like this. I think that's really important, because not everybody is going to have equal access to that, you know, good standard of care, but that, you know, with persistence and, unfortunately, self-advocacy.
I think it's not good standard of care. I think it's, you know, specialist care, and, you know, does everyone need a tertiary endometriosis specialist? And the answer is no.
Yeah.
And actually, a lot of this can be done incredibly effectively in primary care. I also think now, with the move towards women healthcare hubs, that will also perhaps allow those with a special interest to be able to offer more access to these type of things in the community.
Yeah.
But I think it's also, we often, when we're talking about hormonal options, yes, there's a plethora of options, but often we'll be factoring and going, well, look, there's this, and this. But actually for you, because you've also got really heavy periods, or what you're thinking about in family in terms of a year and a half's time, what your other risk factors, actually for you, of these 5 different classes, this one's probably the one I would go for first. It might not work, but I think that would be the best one first.
Yeah.
But hopefully in the future, we will also have better tools to be able to say, actually, this is the one you're likely to respond to, as well as be able to offer people a wider variety of options on our kind of platter of endometriosis treatments.
Yeah, definitely.
I suppose, that's one of the things that I was kind of thinking of with all these trials. The outcome of that is always going to be that there's more knowledge of endometriosis for GPs as well, that kind of empowering GPs to understand endometriosis more, and maybe being able to look at something and go, well, there's boxes here and boxes here that are ticked, which means that we can kind of go through that process of what treatment is going to work best. But that can only happen when, you know, the trials are completed and you have all that information, that wealth of knowledge to pass on as well.
And also, I think we've got a real need for hormonal treatments. Actually, a lot of the studies that have been done of developing these hormone treatments, we can show that they are much better than taking a Dami-Pol. But actually, we don't have really big studies where we've really big studies where we've compared all the different hormonal treatments against each other. And I think that's something that would be a real benefit if that sort of study was done. But those are enormous studies and they're really expensive. So it's, you know, it's a difficult time for any form of clinical research, whether it's Alzheimer's, cancer, endometriosis. It's a difficult time at the moment with funding. So it's, you know, we all recognise within our space what the priorities are, and we're really fortunate that there was something called a James Lind Alliance Priority Setting Partnership that was done nearly 10 years ago now, with over 850 people with lived experience, as well as researchers and clinicians, all trying to distill down what are the most important things that matter to those affected by this. So trying to, you know, address those questions, but it's a difficult time for any form of research at the moment in terms of funding.
Yeah.
Absolutely. And I suppose I'm going to wrap it up by just saying, are there any other trials that you're working on or have worked on very recently that you kind of wanted to chat about? Because you've chatted about Esprit 2, which is amazing.
We've talked about
Endoflare and
Epic and Endoflare a little bit. But actually, the thing I'm really excited about at the moment is using PET imaging for endometriosis. So we're doing a study called PET Endo. So PET is a type of imaging technology that we've been using for decades, particularly in cancer. And it allows us to identify cancer cells that can't be seen on a CT or an MRI. And we know with endometriosis, we can only really reliably see deeper ovarian endometriosis with ultrasound or MRI. So there's a real need for a scan that ideally could identify superficial endometriosis as well. Now, when the type of PET imaging we used in cancer was tried in endometriosis, it didn't work. But to me, that wasn't surprising, because the tracer that we use in cancer goes to cells that are using lots of energy. So it's a sugar-based tracer. And we know endometriosis can be really scarred. And if it's really scarred, those cells aren't going to be using lots of energy. So I think it was completely unsurprising that when they did those trials looking at the tracer that they use in cancer, it didn't work in endometriosis. But there's been a real kind of advances in PET imaging in terms of the different types of radio tracers that are available. And there are some that are now really well aligned to endometriosis, whether or not it's tracers that will bind to hormone receptors, to scar tissue, inflammation, also a cell called an activated platelet, which is, so if you think about these lesions, they respond to the changes across the menstrual cycle. You can get microscopic bleeding in lesions, but also you can get aggregation of these platelets in the context of inflammation. So we've got these tracers that are really much better aligned to endometriosis, but we've also got a very sophisticated new type of PET scanner here in Edinburgh. It's one of only 5 in the UK, and it's called a total body PET scanner. Now that's a bit of a misnomer. It scans about just over a metre of the body at the time, but it means you can scan most of the places that would get endometriosis all in one go. But also crucially, because it's a very sensitive scanner, we can really, really drop the dose of radiation with this scan, which means it's something that we can actually do in young women of reproductive age without being anxious about the risk for cancer or the impacts of radiation exposure in the future. So we've already done one study where we took 30 women who we knew had endometriosis. We knew exactly where it was because it had all been confirmed surgically but not removed. And we've used these 2 different tracers in them. And it's been really exciting what we've been able to identify, including seeing lots of superficial endometriosis as well as disease on the diaphragm, on the appendix, stuff that we couldn't see on an MRI or CT. So that's been really, really encouraging. Now, obviously, this is very early days. We're now doing the next part of this study. So taking people who've got suspected endometriosis and scanning them before they're due to have a laparoscopy. And then we have to compare the 2 things together without knowing the result of one before we interpret the other. So that's going on at the moment. And I'm really excited about this. I think first and foremost, the potential of a scan that could reliably identify all subtypes of endometriosis is really exciting. By also knowing exactly where in the body it is and what subtype it is, that also might have an implication that if we're planning an operation, who needs to be there at that operation, how difficult it's likely to be. But I think for me, the most exciting thing is if we can not just identify the endometriosis, but identify whether or not it's the more inflammatory kind or the more scarred kind, that might have an implication for how someone responds to a treatment. So that really exciting opportunity, again, as part of all the other ways we can profile endometriosis, so doing the tracking, looking at the gut, looking at inflammation, looking at your genetics, but also add in a scan to then help say, right, for you, this is your endometriosis, this is where it is. We can give you some information were you to want an operation about what the potential risk, benefits, complexity of that would be. But actually, more importantly, with particularly all these newer treatments coming through from endometriosis, are you likely to respond to them? So, I mean, I think this is, we're really excited about what we've got so far. It obviously needs a lot more validation before we can be absolutely confident about it. And I think it will only be a research tool for, the next few years. But ultimately, I think this is really, really exciting technology. And I think it's particularly this very sophisticated new scanner that we've got that's so sensitive, and we can drop the radiation so much that you can actually now scan, babies, pregnant people. It's really, really exciting. So that's I think there's lots of things I'm excited about what we're doing at the moment. But for me, that has been really thrilling, seeing superficial endometriosis, but also seeing how the signal changes between people who are on a treatment and who are not on a treatment is absolutely fascinating.
Amazing. That does sound really good.
It does. I think it's so exciting for patients as well to have access to this kind of information and to hear about these things from people that really do care about it, and they can feel very kind of involved with these studies. I mean, none of them could kind of go ahead without the patients that kind of volunteer themselves to participate in these. I think Endo 1000 is such a fantastic opportunity to do that, because that allows people to kind of participate in research and feel like they're making a difference from across the whole UK, not just at a kind of specialist centre, but you can mail your samples in, and all of the information that we get from everybody is super important to progressing kind of these studies that are always going forward and that are always providing hope for people in the community, I think, as well.
Absolutely. So I'm going to wrap this up by just asking you maybe what I should have asked you at the start, and it's again quite a broad question that wasn't on my notes. Sorry. Why did you get into endometriosis care or research?
So I got into endometriosis research because I was diagnosed with endometriosis when I was 16. I had a pretty horrible diagnostic process. I wasn't really listened to. And that kind of motivated me once I had found out to think, I want to do something about it. I don't like living like this. I don't like the condition. I don't like the way that people are suffering. Being part of that community was definitely a huge motivator. But I think I've always loved biology, and I just thought, someone's got to do it, basically. And there's a fantastic team of people that are kind of super interested in that. And I just thought, that's the path for me, to be able to use my kind of personal experience to motivate me with the research side.
Amazing.
So I don't have endometriosis, but I obviously I'm an obs and gynae consultant. I now just do gynecology. But when I first started doing obs and gynae, I always knew I wanted to be within the surgical aspect of the specialty. But what was really impactful for me when I was quite a junior trainee, the initial bits, everyone's excited about labour ward, and I still think handing someone their baby is one of the greatest things you can do as a doctor. But actually, away from the drama of labour ward, I was really conscious that there was these conditions in gynecology that were so debilitating, and actually people weren't being offered very many options, and the options they were being offered weren't particularly evidence-based. And at that point, Andrew Horn had just set up the first multidisciplinary pain clinic for pelvic pain in Scotland. And I was fortunate enough to be involved in that from a fairly early stage. I did some research with Professor Horn looking at neuropathic pain in patients with chronic pelvic pain. And it made me realise that actually there's an awful lot that can be done already for these people. We don't have silver bullets. We can't provide perfect resolution for everyone, but actually there's a load we can do. And then doing more and more clinical research, I always knew once I've been in a lab, I would prefer to be with a patient. So I definitely like clinical trials more than pipetting. I probably don't have the discipline or patience. I'm in awe of what you guys do. But I liked being part of clinical trials, and they're an absolute roller coaster of a ride, and they are very much a long-term project. Many of the trials we do take several years. So you have to have that tenacity and perseverance to get there. But being part of something that's actually going to change care, that's hugely exciting. And also, I am constantly inspired by all the patients I work with. They are an amazing group, but it's really exciting and really privileged to be part of something that hopefully is going to lead to better care for people in the future.
That's amazing. And I am sure that, you might have seen comments online and things like that. There are people saying that, you guys are giving them hope, that this is like the most amazing work ever. This is God's work, the Lord's work. And that I think people are just really excited to see people making a difference. And so if nothing else, hopefully that gives you the motivation as well to say you're doing the best that you can, and everyone is so excited to see what comes out of our labs especially.
Yeah. It's so fantastic to be involved with such a group of people that are so passionate as well. I think everybody that works in our team absolutely loves their jobs, and you can just tell in the kind of quality of the work that they produce, but also how they feel about the topic in general, just how passionate they are. I think it is really encouraging for patients to know that there are people that really care about it, working on it all the time.
Absolutely.
Yeah, and I think that breadth of people we work with, from these amazing researchers in the labs to imaging people. I now work with people from so many different specialties, stealing stuff from, not actually stealing stuff, but sharing ideas and approaches from oncology, from inflammatory bowel disease, from liver disease, from lung disease. And I think that's one of the things I really like being part of the Institute for Regeneration Repair. It brings together all those different researchers from different disciplines, but actually a lot of us are all studying the same pathways. And so I think that I find a really exciting part of being in that setup, and that opportunity to work with so many people from so many disciplines, as well as all the patients. I love my job. I really, really love my job. I think if you look at clinical training at the moment, a lot of people are finding it hard at the moment and tough, but I still genuinely loved my job. And I also quite often come home and say, guess what I did today, or guess what happened today. I love it.
Amazing. I'm so glad. And it's, again, just always so great to hear about everything that's going on around endometriosis and around me that maybe I don't know about as well. So thank you both for chatting to me today. And we will have another episode very soon. So thank you very much. Bye.
Bye.
Look at that.
Totally didn't look at the camera.
Endo 1000 is a study within the University of Edinburgh. If you are interested in finding out more, you can follow us on Instagram, Facebook, TikTok and LinkedIn at Endo 1000 Project, or via our website www.endo1000.com. If you are looking for information about living with endometriosis, head to www.endometriosisuk.org for resources and support.